Dr. Villicana. I mentioned a little bit, you'll have to go back to the first introduction to hear the full one, but he's an amazing transplant nephrologist. He's the medical director of Loma Linda University Transplant Center. And it's my pleasure to introduce Dr. V, who's going to talk about cancer and how to prevent it.
Yes. Okay. So we'll talk about prevention and screening, which goes hand in hand. Now, what if in the, worst case scenario, what if you've already had cancer, but you're on dialysis or nearing dialysis and you'd like a transplant? How long must you wait before you could be active on the list? There's some nuances, it varies. And then lastly, what if you develop cancer after you've had a transplant? So this all came on, sometime after your surgery. And we'll talk about all those things as well. All right, so the next slide is geared mainly for those that are on dialysis or nearing dialysis, and kind of how we start to look at screening. In general, for the most part, it's pretty similar to anyone really, depending on it's all about your age, it's all about your personal history, your family history. That's kind of where it all starts. Now, at the very top, it says, if you're a transplant candidate, if you're not a candidate, maybe because maybe medical issues or not feeling so well, maybe that might kind of go on the side until one feels a little bit better to be able to do these tests. Because with some of these tests, there are other things that could happen as a result of a test, like maybe a false, read, like maybe a prostate test that looked off, and then there's a biopsy, and then there's like a complication because of the biopsy, or same goes for a breast issue or other things like that. So it's not just as easy as just ordering something and then showing up for it. There are some drawbacks to some of these tests, which is why we think about them. So, but on the left, you'll see, and I have more slides on some of these individually, but there's talking about breast cancer screening in general. It's around the age of 50. There are some guidelines that suggest mid 40s. And of course, if there's like a strong family history or if there's genetic issues that's obviously something different. This is just for the average individual. Colon cancer screening. I mentioned early in the morning that it typically is starting at age 50, but more recent guidelines, because of unfortunately some worrisome signals, are picking up colon cancer a little bit earlier. So now it's mid 40s is what many of the guidelines are. That's all changed in the last year, I would think, just from what I've seen. Lung cancer, hopefully doesn't apply to many current, for sure no current smokers, but maybe if you had a past heavy history of smoking, there are some special CAT scans that would be of benefit to screen. But that's really for a very small group of individuals, not really more for mainstream. Cervical cancer with Pap test and the HPV, the papillomavirus, that's been implicated in this type of malignancy cancer. There's different guidelines there, and then of course prostate on the right. And those are the big ones, but we'll dive into those a little bit. Most of them we'll each talk about them a little bit more deeply. All right, so this is like another schematic specifically for those that are awaiting a transplant. And as I mentioned earlier, lung cancer, you don't really screen unless you have a heavy smoking history. Liver cancer is screening not normally done unless one has cirrhosis. So if you have cirrhosis and are maybe thinking about a liver transplant, or maybe need both the liver and a kidney transplant, which happens from time to time, our liver team will follow that up with maybe once or twice yearly ultrasounds or CAT scans, just to make sure that liver cancer does not develop, because cirrhosis is a very big risk factor for that issue. We'll talk about prostate a little bit later. Skin and lip cancer, just general self-exam. Later, in a few minutes, I'm going to definitely dive into skin cancer after transplant, because that's a major issue. And I think I'll show you like some slides as to why that is. Breast cancer, we spoke about. Kidney cancer, and I have a couple slides a little later about that. It says screening not recommended by most guidelines. That's true. However, in people who are on dialysis or with a low GFR, there is a risk of increased risk of kidney cancer, and I'll show you a slide or two on that. We talked about colon, and I think I have 1 or 2 slides later, and then we discussed cervical cancer screening as well. So this is kind of where some of this comes from, some of the tailored recommendations. You're going to notice it's kind of a funky looking slide, but the gist of it though is that at the very top, this is kind of the incidence of cancer in those that have end-stage kidney disease. Basically, if one has ESKD, you have about 3.5 times or more increased risk of kidney cancer compared to someone who's not on dialysis. And it's basically having cysts over time. One can develop cysts in the kidney, and those cysts can transform a little bit later to becoming cancer. So that's something that we look for, especially while you're waiting for a transplant. Bladder cancer is a little bit more increased risk as well, not as much as kidney. There's certain, cervical and rare cancers such as of the tongue, that's a little bit more increased risk. Liver cancer for those that have cirrhosis, but if you don't have cirrhosis, then your risk is like everybody else. But then at the very bottom in bold, it says the common cancers, and basically breast, colorectal, lung, I'll throw in prostate, that they're about the same risk. So that's good, right? You don't have an increased risk of the big ones or the common ones. But there are some special ones that we need to pay attention to for those that are on dialysis. And even those that have had a transplant but were on dialysis a long time, the risk doesn't just change overnight. So again, this is just a kind of a nice summary of what I've shown you. And I actually showed this one in the morning. I want you to focus near the bottom third. There's something called PTLD. I mentioned that. That's a special type of lymphoma, lymphoproliferative disorder lymphoma that can occur after not just kidney transplant, but any organ transplant, specifically actually the heart and lung transplant recipients are at highest risk, but kidney recipients as well. I see that from time to time. I'd like maybe one slide on that a little bit later. Okay, so this next slide is going to focus specifically just on certain cancers. So this is just purely on breast cancer screening. And I'm sure if you're like me, it's hard to keep up with certain organizations. You'll read online or you'll Google or it'll be in the paper that certain guidelines say this and you thought it was something else. This may explain some of that. This shows different, very big organizations. The WHO, the Canadian Society, American Cancer Society, the US official task force, and then an Australian government entity. The majority are on, you'll notice the recommendations are very similar, except the American Cancer Society they start under 50. So most guidelines recommend starting mammograms and screenings at 50 plus, but for them it's 45 plus. And then of course, if there's any family history, genetic issues, that changes everything. And that's something that with your team, you would decide. SDM means the shared decision-making. So if you're in your 40s, basically it's kind of discussion with you and your team as to whether you want to go for some screening or not. The reason that they say that is because at that age, although there is possibility to have cancer, there could be a lot of false reads with some of these tests that could lead to unnecessary procedures, biopsies, maybe even surgeries. And so that's kind of why that's more of a shared decision. And then around 50 is where everyone is in agreement that should happen at least every couple of years, a mammogram. Okay. So the next, I think, I'm trying to think. All right. So this is really complicated. So I'll just summarize. At the very bottom, it says solid organ transplant. Sorry, very top, and that's the group we'll focus on. Other groups, if you had a stem cell or other immune issues like lupus, things like that, are further down. But the very top, basically saying that if you're under 30, you should have a Pap smear, and if you're over 30, you should have that plus checking for a human papillomavirus or HPV, which has been implicated in this type of cancer. So again, the idea is, though, that please keep up to date with your testing. Really, regardless of whether you would like a transplant or not, it's good for all of us. Now, switching gears to colon cancer, kind of a busy slide, but it's colorful at least, so we could kind of follow along. In purple, though, is the main columns. Those are true colon cancer, right? So it's true colon cancers. The other bars are, polyps, basically differing on size. They're considered benign for the most part, most of them. But in purple is actually true cancer. What you're going to see, unfortunately, is colonoscopy, which is probably the most difficult to pull off, is really the top way to detect colon cancer. And if you have a perfectly clean one, which is not always the case, and with no polyps, nothing like that, then you'll get 10 years, which is nice to not have to worry about anything. Of course, assuming there's no family history, personal history, etc. But now some of you may have already had some of these tests. I know I've been asked to do one. I haven't even done mine yet, but it's in my drawer. There's a kit. But so the FIT testing or FIT DNA, these are tests that can be done every year. And, you just, it requires a small stool sample to check for certain, it's not just for blood, it's actually for markers of possible colon cancer. So that's one way to do it. You got to do it more often, though. It doesn't give you the full 10 years that a perfect colonoscopy could give you. But there are benefits of all that. So there's different combinations of what colon cancer screening means. And they all, many of them have good, even away at the right, the FIT DNA test is basically like a stool sample test, and it has very good detection of colon cancer. You see it's 92%. So with the colonoscopy being 95. So it's very, very good. You just have to do it every year. And so it's hard to kind of keep up with that at times as well. So, and the reason, I think the next slide's there's a little bit of a lag time there. So this is basically colon cancer and the age as to when there's a takeoff, as to when it starts to become more common. You'll notice that it's pretty rare under 40. But you'll see that around 30, the line starts to kind of lift a little bit right off of the bottom. There's a little bit of movement. And for sure, like once you're around 50 plus, there's definitely more, of an upward trajectory. But you'll notice though that in your 40s though that things are already happening. And that's why there's been more recent guidelines to recommend checking for colon cancer beginning at the age of 45. So that, and there have been some high profile individuals before, who have suffered from this in even younger than that. So I'm sure some of you may know people under the age of 50 who've developed colon cancer. So that's kind of where that comes from. All right, switching gears away from the colon. Now for the guys, prostate cancer. Again, at around 50, there starts to be some activity in terms of increased risk of prostate cancer. Very low, very rare under the age of 40. Maybe a little activity in the 40s, but definitely 50 plus, you start to see something. Some groups more than others. African Americans definitely have a higher risk of prostate cancer. That's fairly well known. So that's that should be noted. And the next slide kind of explains why someone might have an abnormal PSA, which is the blood test for those of us that need prostate cancer screening. Like, it's not just cancer that can make that test abnormal. Many non-cancer reasons can cause that. So unfortunately, that could cause one to get a prostate biopsy or two when maybe it wasn't needed or it just wasn't indicated. But at the end of the day, no test is perfect. The PSA has been very, very controversial for those of you that follow that. There's some guidelines that even say don't even check it or ask your doctor. It used to be a very strong recommendation to check, but now over the years, it seems like it's getting to be more of a shared decision with the patient, the person that would like the test, all of us, and the team who's helping out. So anyways, but there's quite a list of reasons for you to have a false positive abnormal test, and it's not cancer. Let's switch gears to those that would like a transplant but have had cancer before. So for us, we have to basically weigh the risks and benefits of transplant for someone that has a history of cancer at some point, hopefully long ago. The longer the better. But you obviously would like someone to come off dialysis. You would like for someone to receive a transplant. But at the same time, we would not want to have any role in making another issue worse or accelerating a situation that maybe was kind of stable, but then became unstable once we did our medications, and they have their risks as well. The transplant medications can raise your risk of certain malignancies. Okay, so this is kind of how we look at things. In the middle, it says when to actually do the transplant. In the next slide, we'll be more specific on time. So kind of in the upper right quadrant, it's like the factor, what kind of cancer, when was it aggressive, was it not, hopefully it was 20 years ago or long ago, did it respond to treatment well, whatnot. On the left, it's what's your situation? Do you need a liver and a kidney? Do you need a heart transplant? Obviously, there's certain things that can wait a little bit longer than others. On the left is more for one that would like to receive the transplant. Is what's their quality of life? Have we kind of helped the other issues? Like did someone quit smoking? Did we address the medical issues? Genetics as well. On the lower right is the immunosuppression that we discussed in the morning. Unfortunately, our medications, we try to help, but sometimes we do make things worse. In the morning, I kind of pounded on the fact that we can make high blood pressure and sugars, diabetes worse. This afternoon, I'll now say that some of these medications could increase your risk of cancers, specifically skin cancer, but not just that, but it's felt that it just increases your risk overall, just because it does alter your defenses. There are certain viruses that can cause cancers that pretty much exist because of the immunosuppression. I have a slide, I think, coming up later on that topic. But yes, so these are all the things that we think about. Say you're in the office and you had something hopefully long ago, but even if it wasn't that long ago, then we just kind of factor all these issues in. All right. So what everyone asks who's been unfortunately in that situation is, how long must I wait, or am I a candidate at all? Now, I apologize. I try to get this slide. It's actually our date. We did a publication early in the year. I tried to kind of make it with the larger letters, but I think hopefully you could see some of it. So at the very top is non-melanoma skin cancer, which is very, very common, as you know, especially in areas that have a lot of sun exposure. In general, there's really no wait time. If you just had, say squamous cell on your hands or basal cell on your nose, that in general, that's fine. Obviously, melanoma is a different situation. If you have very localized melanoma, there's really no wait time. If it's like very mild, it isn't considered an aggressive situation, aggressive cancer. So you probably need to wait at least 3 to 5 years. And if it's, very severe, odds are most centers will probably not consider you, just because of the risk of aggravating it after transplant. Again, skin cancer is the number one cancer after surgery. So that's why we're so serious about it beforehand as well. Then the prostate, there's actually a development where you could actually have prostate cancer, and the urologist would like to just observe, just because it's mild, or maybe even mild medium, and we're okay with that, because as long as you have good follow-up, prostate cancer is not something that normally spreads really, really quickly. It doesn't move super fast. So as long as there's good follow-up, we're okay with even, as a matter of fact, we just did that about a month ago. An individual with kind of an early mid prostate cancer, and we did the transplant, knowing that, but knowing also that they have good follow-up, and knowing that things move slowly in that arena. And there's a bunch of other examples. Breast does come up quite a bit. If you have a history of regular, maybe stage 1 breast cancer, it's at least 2 years of wait time is what, that's kind of a common theme. 2 years, 2 to 5 years is a kind of a common theme, but many more are now in the 2-year wait period, which is, I know it's a long time, but it's at least better than never or 5 years, which is how it used to be when I first started. That was the case before that. There are actually a few, like localized kidney cancer. If it's like all removed by, say, removing the kidney, and there's no spread or nothing, and it's the size is not that big, people can get a kidney within like months after transplant. Sorry, after that, the kidney removal, they're considered cured, basically. So that's kind of nice. Okay, moving forward. Sorry, there's a delay here. Now, one thing that's a pain, I think, for anyone who wants a kidney transplant is all the testing that we require, and or require again, or it wasn't done right, or all those things, as you know. So a lot of that does include colon cancer, all these other cancer screening. But after transplant, there are no guidelines per se, other than like what everybody, for everybody else. And there's not going to be anyone hounding you as much as before the transplant that you need this or you need that. And this just shows the uptake of screening, from 1 to 15 years after your surgery. And you'll see that it's not that high. It's, cervical cancer is probably the best one where there is testing. But, breast cancer screening is fairly low. Even colon cancer screening, the big ones, all, these 3 are big, and it's not, very, people aren't really getting those testing done. There's actually a study that I'm about to show you. This is from Canada. And they studied, over 8,000 patients. And in the end, they identified 6,400 based on certain criteria. But if you focus on the left, it says SOTR is solid organ transplant recipient that are eligible for breast cancer screening. So there are like 1,500 individuals, and only 134 were always on it. So like maybe 10%, like 9% were always on top of it. And the others, majority were, not always up to date. So that's one thing. And so now we move in the middle. Cervical cancer screening is a little bit better. So that's probably what looks like a 30%, where people are always up to date, and then 70%, aren't up to date or they skip. And then colon cancer on the right, that's about 25%. About 1,000 people are always up to date out of the 4,400, and then the majority are not. So it shows that that people aren't, maybe they're just busy and hopefully enjoying a good transplant experience, but at the same time, we need to always, all of us really need to be up to date with our testing, because we all need them regardless of transplant status. Okay, so they just showed to see if you're under the care of your general doctor or still under the transplant specialist. And we both do not a great job. At the very beginning, in the first year, obviously you're with the transplant center the most. Over time, you're not going to see the center as often as you did the first year or two. We see everyone every year, at least forever, but some places don't. And honestly, even when I see someone who's 7, 8, 12 years out, I'm not necessarily thinking of certain kinds of tests, because I'm assuming that their primary care physician has been addressing it. So I guess my point on this one is, please make sure you have a good primary care physician, preferably before the transplant. They're super valuable. That's what they focus on, preventative aspects, which are very, very key, and more important really than reacting to whatever else is happening. So it's always better to do the testing up front. Okay. So I mentioned skin cancer, and skin cancer is, sorry, I kind of lost my screen there. There, okay. So there's different groups who are considered at high risk, medium, low risk. And I'm going to show you next. I think next is the where that came from. Like, how did they, who's at risk, basically. But skin cancer is definitely probably the biggest issue after transplant. So I'm trying to advance my slide here. It's almost like I'm missing, sorry, there we go. Sorry about that. Okay, so the risk categories for developing cancer. I know it's pretty busy, but let's start way at the top. So it's a lot of it's stratified. So if you're Caucasian or white, yes, no. Just to kind of cut quickly to the chase, if you're white or Caucasian, you have the highest risk of skin cancer. We know that. If you had prior skin cancer, then you're at risk for future. If you're older than the age of 50, you are also at highest risk. So way on the right, you'll see very high risk. So that's a Caucasian who's had skin cancer before and is over the age of 50. That's a very high risk group. Another high risk group is anyone who's had a heart or lung transplant. They're at highest risk because they use more medication to suppress your immune system. Now, way on the left, in green, you'll see a few green boxes that are considered low. So that would be non-Caucasian, never had skin cancer, under the age of 50, you're pretty low risk. There's actually more skin cancer in males than females, and I'll show you that that slide as well. But there's like a lot of factors that go into it. There's even like an app. I think it's an app because I got it on this website, and it actually shows you, you enter certain things about yourself, and it actually gives you your risk at 5 and 10 years of skin cancer. I think it's called the Suntrack screening tool, I think. So you just put in, different things, and that kind of we already alluded to. For kidney individuals, you would key in abdominal TXP or abdominal transplant, and then all those things. But this individual, just as an example, is a Caucasian female who's over the age of 50. No prior history of skin cancer, but had a heart transplant or a heart lung transplant. Her risk is 15% at 5 years, or over 30% at 10 years. That's pretty high, very high. So they would definitely need to be screened annually, just for going to the dermatologist. And actually, we do recommend that for most individuals who've had a transplant, to see a dermatologist for just a general skin check once a year, just to make sure no spots or anything that maybe we blow off at times that maybe shouldn't be blown off, and things like that. So again, skin cancer is an issue. Another thing that's interesting is that those have been transplanted. This is kind of an older, well, actually it's not that old, but in terms of the era when you had your transplant, whether you had your transplant in maybe in 2003 versus 2008, it seemed like there was more individuals who were transplanted more recently in 2008 compared to 2003 that developed skin cancer. And I'll show you that data right now. So again, basically, Caucasian or white has the highest risk. Thoracic transplant as well, over the age of 50, and slightly if you were transplanted in 08 versus 03, in this cohort, you had a slightly higher risk. I imagine it's because we are using, I think, more heavy duty medications, unfortunately, over time. And that does really put the risk of skin cancer. This is kind of a busy slide again, but how do we react when, say, someone is diagnosed with a cancer after transplant? In general, we will adjust medications. So if you happen to be on three types of medications, say Prograf, prednisone, or CellCept, we at least would reduce the CellCept, maybe even stop it altogether. Sometimes there are certain other classes of medications that one might switch for the other, but there will be adjustments. So please, if you've had a transplant and you've developed skin cancer or any type of cancer, please let us know right away so we can kind of tailor your medicines appropriately to make sure your risk we minimize things as much as we can from our perspective, and so that everyone has a good outcome. Okay, I mentioned PTLD earlier, or the non-Hodgkin lymphoma in transplant. You'll notice in blue, that's the heart transplant, and they're at highest risk for this issue because, again, the medications that they use are heavier because the heart requires that. But not to say that kidney transplant, especially in the first few years. So this is something that can definitely happen. Actually, it's not just the first few years. The first few years is the highest risk, and then what it doesn't show later, I think it just goes to 6 years, but I think there's like another bump close to 10 years where there's a risk a little bit later. So these are things that we'll be watching out for, and that's on our mind as well when we see you. I mentioned kidney cancer earlier. So this is your risk of kidney cancer, kind of according to your GFR. So the lower your GFR, the higher the risk of kidney cancer. So anyone with a GFR under 30, basically a stage 4 or stage 5 CKD or on dialysis, has increased risk of kidney cancer. I did not show further data on this, but there is data to show that the longer you've been on dialysis, the more your risk. So if it's like, say, 6 years, around 5 to 6 years is where dialysis is where there starts to be a little bit of an increased risk. And definitely if anyone's been on dialysis more than 10 years, that goes up even higher. Other certain groups as well, African Americans also have a higher risk of kidney cancer on dialysis. So this is something, how do we address this? At least at our center, and I think many, we request ultrasounds or CAT scans of the abdomen to look at different things, but that's one of them, is to see if there's maybe a kidney spot that needs to be followed. Sometimes we catch things and nobody knew about it, and them trying to get a transplant, and we did the testing, and it kind of came about, and they get their kidney removed or partial kidney removed, and then they move on and get their transplant almost like nothing happened. So that's probably the best outcome when that occurs. I just have a couple more slides. And I think the next one's also on kidney cancer. I'm just having an issue with my, I don't know why it's
the gremlins. There's gremlins everywhere.
Yeah, it's like it almost skips a slide at times. There we go. Okay, so then this one again, just showing that renal cell carcinoma, or basically kidney cancer, amongst those that have received a transplant, there's definitely a fair amount of activity, unfortunately, the further out you are from transplant. So another way, we also screen afterwards periodically, and it's not a bad idea to screen. Sometimes, your team might say, hey, let's look at your old kidneys. And you're like, well, why? I was on dialysis for 10, 12 years. I didn't make any urine. I already had a transplant. So what is that kidney doing at all? Technically, it's not really doing much in terms of providing it much function, but it could be a harm to you. It could harbor some cysts that may have transformed over time to something more serious. So that's kind of why we do that from time to time as well. Okay. I threw in this next slide. It has nothing to do with anyone having cancer, or like someone who needs a kidney having cancer, or someone who's had a kidney who has cancer. This is actually, I just kind of came across it because it just comes up. So once in a while, we are offered donors, kidney donors who passed away, who had some type of hopefully remote history of cancer. So many times you won't hear about it because we tend to pass, but sometimes we don't. Sometimes obviously it's a benign tumor. We feel there's no risk on the left, minimal kind of on the left of center. Like certain skin cancers, if they had skin cancer, or like a very, very local cervical cancer, or like maybe even like a small kidney tumor, the risk is very minimal. And actually that happens sometimes certain living donors actually over the years have wanted to donate their kidney, and in the testing, sometimes we notice like a little a kidney spot. And so beforehand, of course, with consent and discussion with the person who's going to donate and who wants to receive it, sometimes the decision's made is say, hey, we're going to take out this kidney. You're going to donate it anyways. We're going to look at that spot. If it's a little benign thing, then obviously not non-issue. But if it's a small little cancer, what would you like us to do? And many times the outcome is like, if it's small and if it's contained and they're going to donate it anyways, then I'll take that kidney. And that happens. It happens from time to time over the years. Now, the way on the right, though, there's obviously very serious situations, like say a donor who passed away had melanoma or certain of the big, breast, colon, or lung cancer. You're not going to hear about that. We're not going to really go there. But on the way left, no risk or minimal risk. You will see that, and even sometimes low risk in the middle. There's certain things as well, but there's a lot of research on this. At the end of the day, we want to use as many good kidneys and as many organs as we can in a safe way that does not pose any harm or very minimal harm at all to the individual that might receive it. So I thought this was kind of interesting slide as I was prepping this talk, because it doesn't really apply to anyone who's waiting, but it does kind of indirectly, because you might be offered this situation, and there's a lot of thought that goes into this. So you never know. All right, and then lastly, I'm throwing in one last vaccine, not COVID. I already talked about that quite a bit. So viruses and cancer have a direct link. So I mentioned cervical HPV, but the post-transplant lymphoproliferative disorder, or PTLD, 90% of those are driven by EBV, or Epstein-Barr virus, which many people would recognize as, they used to call it mono, right? Mononucleosis. So viruses and cancer are definitely linked, unfortunately, and not to say that all viruses can cause cancer, but there are more and more data on different things. So I guess the gist is, please get your vaccines. We talked about that quite a bit this morning, and for different reasons. And as I wrap up, let's see. I think trying to get to my last slide here. It's almost not, doesn't want to let me go. Trying to see why it won't.
Oh, while we're waiting, while you're trying to figure out,
There it is.
Somebody had a question. I've had a transplant and both native kidneys removed. Is there a chance of getting kidney cancer in the donated kidney?
That is really rare. Donated kidney cancer is very rare. But obviously that could be picked up with ultrasounds and things like that. But that is very, very rare. But unfortunately, your original kidneys, though, can harbor that. And since both have been removed, then the risk is never 0, but it's pretty close to 0. Yeah. So these are some of my conclusions. Screening guidelines for cancer are similar, for the most part, to the general population, with some slight differences. Many individuals with a history of cancer are still eligible for a transplant. Depends on how much time one must wait for that, but many are still eligible. Kidney cancer is higher, as we just discussed, those with ESKD, CKD. And then skin cancer is the most common cancer after having a transplant, and does need, in general, yearly screening. So, and with that, thanks very much. I don't know if there's anything else, Lori. I know in the chat.
There's a couple of other couple questions, and we'll wrap up. But thank you so much. It was very informative. I think this is one of the best presentations I've seen on this topic. And knowledge is power.
Oh, thank you.
I think I know the question in this one, because I think you wear roller skates. You're so busy right now to get everywhere you need to go. But Robin Sales asked, how common is it for a transplant nephrologist to act as a PCP? My current and retired past transplant nephrologists have acted in the capacity, as well as the transplant related position, also watches out for cancer issues.
Right, very, very rare for a transplant these days, a transplant physician to be like a primary care physician. It's just really difficult to really be involved like that. We do about 220 kidneys a year, and even say over 5 years, that's like 1,000 individuals. But we're talking about relationships longer than that, right? So it's just something that unfortunately most transplant centers are not set up that way. To be honest with you, we're not like that, but some transplant centers aren't not even set up to really provide much nephrology care after maybe a year or so. But yes, I remember that there was an era where that was pretty common, but as transplant is becoming more common and in more volumes, unfortunately, it's not necessarily that easy. But yes, I do know a few individuals who've done that.
Well, and I think too, in fairness, and I can't figure out how to stop sharing your screen right now. I did it earlier. No, I should be able to do it, and I can't do it. I'm having some gremlins over here. But my nephrologist does act as my primary care physician, which is wonderful. But I do believe that, there's so much going on. Sometimes the nephrologist isn't kept up to date on all the primary care needs because they're focusing on the kidney. So,
Yeah.
You have to really be, I found it. Yay. I think you have to be really aware of that. And, I have to make sure that I get I have like 12 doctors, from the dentist to the eye doctor to the ear doctor to the gynecologist to the dermatologist. I mean, it does become quite a long list, but an ounce of prevention is a pound of cure.
That's right.
It's so true. And I've been dealing with gynecological cancers for over 25 years. And with a transplant, and I see an gynecologist, and he's on top of it, and I've not had any issues as far as it progressing. So I can't tell you how much those appointments matter. And it's just being preventative. And and then I also want to advocate, especially for any kind of doctor, is that it's really good when you go to find if they treat other transplant patients. Because when I was dealing with gynecological issues, if I went to a regular gynecologist, they just freaked out. I had to go to one that saw a lot of transplant patients. So make sure that you do that, because they can get freaked out by just, a couple labs and I don't know what to do.
True.
So it's important. But thank you so much, Dr. V.
You're welcome.
You're a great speaker, and we're so glad to have you on the RSN board. I can just imagine where you're going to go. You're going to be leading the whole country, I hope.
Actually, I got to go
transplant. Transplant. All right. Have a great day.
Thank you.
All right.
Appreciate it.
Bye-bye. And a shout out to our corporate mission partners for making this happen.